So welcome, Professor Morris's class and my class. We are on week 8. Next week, we're going to be starting reviews again for exam 3. This week, we're going to be going over chapters 41 and 45, which is GI and GU. And you're going to be really interested in finding out that there's so many diagnoses in the pediatric population that you've never heard of before. So I'm going to try to explain them to you in a manner that you understand and that you can remember, because the symptoms are something you're going to need to know. I mean, we have generalized GI, GU things, but there are specific to certain ones. So as I talk about them, just listen to if I emphasize these are things that you're going to have to know. Khadijah, could you come on camera, please? Miss Joy. Thank you so much. I appreciate that. One thing, just remember keeping your whole face on camera, please. So that is your attendance. Ariana, yes, thank you so much. That is part of the attendance. Savannah, I can only see half of you, so please give me your face. And okay. So this week you have a lot of stuff that's due. You have a case study. You have your pediatric assessment assignment. That is a 3-part thing. I've already started correcting a lot of them on my students and sending back correcting things as I can. You also have the SERN assignment exam, which is a prep for your HESI, and also you have NCLEX questions. So there's a lot of points on the table this week. So just try to keep up with them. Again, if you're running behind, something happens to you, you can't, just notify Professor Morris or myself. We can always give you leeway if we know before they're due. If you tell me after, I don't know. Okay, so you have to tell me before. So the way I teach class, we're going to be doing first GU, then I'm going to do a Cahoots, then we're going to do GI, and then we're going to do another Cahoots. It sort of breaks up the class, and my students tell me they like it, so we're going to work with it. Now I'm on a new computer. I broke mine, so I hope that I can figure it all out. I've had such a week. My tooth fell out. I broke my computer. Oh well, we will get through this, won't we? What I want to do is this. Okay, let me get out of this thing. All right. First of all, we're going to be talking. Can you all see the slide? Is everything okay with everybody there? You can see it? Because it's showing up different on my screen, and I just want to be sure.
Yes, I can see it.
Okay, beautiful. Thank you so much. So let's first talk about GU, urinary and children. Well, the one thing that we know children do, especially younger children, the most frequent infection we see is urinary tract infections. We know that it is because of potty training. We know it's because children hold things. It's also due to constipation, believe it or not. And we know uncircumcised boys, because when you pull down the foreskin, there's schmegma there. And it's like a petri dish and it grows bacteria. So you're growing bacteria. Again, it goes into the bladder and then causes that infection. Now, one of the things that we need to remember to teach is to make sure if this child has a urinary tract infection, just because the symptoms go away, they shouldn't stop. They need to continue and finish it. Also, many of them want a follow-up urine. So when do we start looking? with these children to prevent these infections because they're young. Their bodies can't tolerate it as much as older people. So again, parents should be very aware of children, their urine habits, how they're urinating, if they're getting frequency. Also, just basic, hygiene. Baths are not good. Bubble baths for little girls is actually not a good thing. And tight underwear and those tight, cute pants that they like to wear that are more of a latex polyester. Cotton underwear is what they recommend for little girls. Also, as they get potty trained, how to rub white from front to back. That's the obvious, right? Well, what about those children that are now adolescents and they're experimenting with sex? Well, many times they'll come into the emergency room, and I've seen many of them come in, adolescents, and I've seen them more than once with urinary tract infections. So if I can get them alone in the room, I will talk to them and ask them, are they having sex? And if they are, I can give some information to say if they urinate after as soon as they can after intercourse, it decreases the incidence of urinary tract infections. So, how do we evaluate it? Well, we need to get a urine specimen. On infants, the only way you're going to do a urine specimen on infants is a catheterization, a straight cath, because we don't want any contaminants and we want to treat that bacteria the first time because they don't have an immune system, right? If the kid is this young, let's say they're premature and they're in the NICU and they're working them up for sepsis, what they do is a suprapubic aspiration. What that is they take a needle and they just put it above the symphysis pubis bone and go directly in. And that's where the bladder is. And they, with a syringe, they pull out just a little bit and they do a culture. And again, it's a really good specimen. There's other ways we could do washes out and put catheters in and, really collect all of the, stuff and slime that could be in the bladder. We could test that. There's also many sorts of x-ray tests. We could do an ultrasound. Let's just look at structures. We can look at a voiding cystourethropy. This is when you have reflux going up the bladder, up to the ureters, and it's an x-ray with a catheter with dye, and it works well. The IVPs are intravenous pyelography. Those are basically kidney stones. So some of the defects that we see with children. In a boy, if they're circumcised, there's a couple things that can happen. Sometimes it gets so tight you can't pull the skin down, and that is called phimosis. There's another time where you pull it down and it gets stuck because you're cleaning, that schmegma that's, collected in there. You pull it down and you can't get it back up. That's a paraphimosis. And it's dangerous because you could pinch off the circulation on the tip of the penis and cause the death of the penis. Actually, what do? Initially, we put cool on it. We try to constrict it, try to get it, so we can pull it down, basically. And it is a urological emergency because of that. Other things that can happen to boys are hydrocele, which is just basic fluid that's going around the testicles. Usually by 12 months, it's gone. Sometimes you can feel that little fluid in their testicles, and it's okay. Again, it's usually not painful or anything. So by 12 months, you do, it should be gone. And if not, they're going to go do a surgery. Any surgery involving testicles, anything perineal, we have to be careful postoperatively about children playing. No straddling toys, no riding bikes, no riding, their little horsey, any of that. Also, they also say be very careful about bathing. When is it okay? That's something that has to come from the doctor. Another thing with boys is when their testicles do not come down into the sac. First visit for the doctor, usually at 2 weeks, they're going to check testicles again. They want to make sure it's there. One of the things that I would ask, if only one is down or none is down, ask, have you ever seen the testicles down? Because sometimes coolness will bring them up. And they shrink up back into the abdominal cavity and you can't feel it. So in order to do a proper scrotal exam, you need a warm room. And that warm room will distend the testicles and you'll be able to feel it better. If we do not have those testicles to come down, usually we like to get them down before potty training, okay? Another condition. These poor males are going through a lot of stuff, aren't they? We have a hypospadias and we have an epispadias. Now, a hypospadias is the underneath or the ventral portion of the penis. The urethra don't come out the tip. It comes out somewhere underneath. It's really crazy, okay? So when they urinate, it comes this way. So you can tell we want to do this corrective surgery before potty training, or they're going to be squirting all over the place, right? Plus, they need to do it properly for mental health as they get older, that they have disformed penis because body image, all right? So you have to keep the foreskin on these children. This might be a consideration with the Jewish religion. They want to do a brisk, they can't. You need that extra tissue. Can you see that penis? It was cut from the tip all the way to the bottom, filleted open, and a cavity was made in order for the urine to go from the bladder out to the tip of the penis. So post-operatively, you're going to have a catheter in there. You don't touch it, you don't play with it, just keep it in a diaper. And usually, about 7 to 10 days, the surgeon will take it out. So, again, you've had surgery on your penis. Again, post operatively, what is your concern? Safety, no riding bikes, throwing balls, nothing that can hurt that area there, okay? Another thing that can happen, boys or girls, it doesn't matter, is something called exstrophy, bladder exstrophy. That means the bladder was born on the outside. Okay. Epispadias is just like hypospadias on the top, but bladder exstrophy is just the bladder was born. It didn't get closed in when in fetal development. It was left open and the bladder is on top. Now, the bladder still works, it's still connected, you still urinate in the right way, but nursing care. You've got the insides now on the outside of your body. So you need to protect it. You need to keep the skin integrity because we have to close it and we don't want damaged skin because it will just dehiss. So our big thing here is to keep the skin integrity for this. You put a diaper on them, they're still going to urinate the same way. Now, they're also saying after the surgical treatment, we have to make sure that we are preventing urinary tract infections. And again, this has a lot to do with keeping that tissue nice and clean. So, care management, again, limit trauma. Always, you're going to monitor anything you're working on the penis or you're working on the female urinary organs. You always are going to monitor intake output. You're going to be looking for infections. I mean, this penis was filleted open. I'm sure postoperative pain they're going to have. Again, wound care, and then, have the parents understand the catheter will be in there, not to touch it, just to keep it in a diaper because it will be draining. Another thing we do, depending whether it's chronic urinary tract infections or we're concerned something with the kidney, we can do a renal biopsy. Now, biopsies, they're actually very similar to the cardiac caths, believe it or not, post-operatively. So again, preoperatively, we're not going to do anything. We're not going to do anything but NPO before they go. All right. These children will be given some sedation because they have to take, with ultrasound, they've got to go through your back into your kidney and take a piece of it. So, what do you think the post op treatment's going to be all about? Well, infants, they make an incision because the kidneys are so small they can't find it. Older children, the ultrasound, they can do it. So you want a pressure dressing, sandbagged, just like you did with cardiac caths. bed rest 24 hours, just like cardiac caths. And because you were dealing with the kidneys, you want to make sure you monitor urinary intake output, abdominal pain in case there's bleeding or tenderness or something's going on there. So that's renal biopsies. Now, one of the most common things that happen in children is obstructive uropathy. That means there's a kink in the hose somewhere. I think vesical ureteral is your most common of all because the vesicle is your bladder and the ureters come down from the kidneys. And whether there's a kink at the where the sphincter is or up the ureter, be one kink, two kink, one side, other side, these things cause the urine not to come down, which could affect the kidneys, cause hydronephrosis. And again, they need to be corrected as soon as we can so we can save kidneys. So this is the picture that's in your book, just showing you all the different things. But remember, the vesicle is your bladder. Now, nephrotic syndrome has nothing to do with kidney failure. Your kidneys are working, okay? This is the biggest common mistake with students. They think nephrotic syndrome is kidney failure. It is not. What is it? Well, the body says, protein, I don't like you, yuck, and it urinates all the protein out of you. So what are you going to see? Protein's going to be in the urine. Where else is protein in the body? It's in the blood, right? Albumin is protein. So you're going to have low albumin in your blood. It also causes hyperlipidemia. And this one is generalized edema. That's what nephrotic syndrome is. You'll see puffiness all over the place, and you're going to see proteinuria, 4 plus. So this is something that is you're going to have. It is not a curable disease. It's chronic, and it is an autoimmune type of thing. So you're going to have a risk for infection. That's the big thing here. Now, there's a loss of appetite. Your inside your mouth gets all swollen and tongue. You tend to bite your cheeks and tongue, and it becomes painful to eat. That's what I've read, why loss of appetite's there. Now, nephrotic syndrome, you gain fluid like crazy. You don't have albumin in your blood, so all the fluid goes interstitial. That's why you have generalized edema. So how do you treat edema, extra fluid in any type of body? Salt restriction, fluid restriction. Okay, intake, output, and monitoring daily weights. That's anything with fluids that you have too much. Salt, fluid restriction, and then children, when they're in this state, they should actually decrease their activities. So management, actually, we give steroids for nephrotic syndrome when they're doing really bad. We want to make sure with the management of it that we reduce the amount of fluid that's being retained. We want to prevent infections. And again, nursing priority. We have a fluid balance problem. We're going to have strict INO daily weights, and we can monitor, is the fluid going away or are we gaining it? Acute glomerulonephritis. Well, you heard of rheumatic fever, right? This is another condition caused by a strep infection that was not treated or was undertreated. Okay. Again, it is something that we see about 10 to 21 days after the initial, strep throat. Symptoms. The strep attacks the kidneys. So they're oliguric. They stop urinating. So what happens when you stop urinating? You swell up. You have edema. Glomerulonephritis is periorbital edema. Nephrotic syndrome is generalized edema. These are things you need to know. Periorbital is when you have the kidneys. Also, kidneys are always affecting with those with blood pressure, right? So if you're gaining fluid, you're going to be hypertensive. You're hypertensive, you're going to get a headache. If you have severe headaches, it needs to be really monitored very closely. because the kidneys aren't working well again. You're going to see maybe a little blood coming out, and you're also going to see also proteinuria with this one. So, how do we treat acute glomerulonephritis? Well, most acute glomerulonephritis can be treated and it can be cured. If it is over 1 year and we can't cure it, it becomes a chronic type disease of them. But what do? We give them, we treat the strep. Again, long-term antibiotics for the strep. So again, care management. You're going to manage the extra fluid. You're going to do daily weights, INO. And on smaller kids, you would be measuring their abdominal girth because a lot of fluids can go there. Again, low sodium, fluid restrictions. And this is a child you have to be very careful with infections and good hand washing. Wilms tumor. We've talked about it already. It's a kidney tumor. That's what you have to know. And it is a nephroblastoma. And again, this is the one that we do not palpate the abdomen and it needs to be surgically removed. The one thing about Wilms tumor is this is a tumor we don't do a pre-op biopsy. Can you imagine if we stuck a needle into that abdomen, into that kidney, or where the tumor is, you have put a hole and now you're allowing metastasis to come out. And we do not do it. So again, they actually do very well. I had a little boy from Haiti who came who had a Wilms tumor, and I found the tumor, and he did very, very well. I followed him closely. So, renal failure. We have acute and we have chronic. Chronic, they're usually born with it, and you have decreasing, function of the kidneys. Acute renal failure can be due to many things. The most common cause of renal failure in children is dehydration. Dehydration in children is dangerous. They need the perfusion, okay? So, acute renal failure, it's not common, but again, I said the most common is from severe dehydration. So, when you see a child, elevated heart rate, coming in with vomiting, we know our priority is fluids, fluids, fluids. Let's get that blood flowing. Let's get those body organs getting the fluids it needs. As I said, chronic renal failure is when you have, less than 50% capacity of function, and it gets less and less and less as it goes on throughout the years. Why do we have chronic renal failure? Well, it could be congenital, you're born with it, but it could be that vesico-ureteral reflux, the bladder up the ureters, it kills the kidneys if we don't get it treated right away. Could be hereditary, I've seen that a bit, or we have chronic pyelonephritis, which is a bad infection of the kidneys, or chronic glomerulonephritis, same thing. And also remember, it could be an anaphylactoid purpura, could be an anaphylactic reaction, could kill one of the organs, which could be the kidneys. And of course, lupus. Lupus can kill any organ. So, how do we manage kids with chronic renal failure? Well, we know we want to try to promote the most that kidney can work for us. Of course, fluid and electrolyte balance is important. And one of the biggest concerns, just like adults, is that their hemoglobin hematocrits are low. So we can give that erythropoietin subcutaneous injections, and that can help keep that hemoglobin hematocrit up more. Any condition with kids, we try to make them live a life that is normal as possible. But if you can think, most of these are 3-4 days a week, 3-4 hours up to 6 hours a day that they have to come in for dialysis. So their lives are in kidney centers getting dialysis quite a bit. Now, peritoneal dialysis is a type of dialysis that's used on your little kids, your young kids. And the reason why we can't do hemodialysis, a big machine, right? It's too much flow, too much pressure. and it will burst the capillaries in the brain. So it's too much flow. So what we do is we insert a catheter into the peritoneal cavity. Okay. This is something that can be done at home. The parents can learn how to do it. The child itself can learn how to do it. It is done under sterile procedure. If you can think, when you have your abdomen is your kidney, you don't want that to get infected because then there's no other way. There's no other kidney. Your kidneys aren't working. Now the abdominal cavity's not there. So again, that's our biggest thing. So what would be our biggest concern? Peritonitis. What would you see? You might see that the drainage is coming out, the fluid color is changing. And what do? You're going to call the doctor and anticipate, yes, you're going to get antibiotics, but you can't give antibiotics without a doctor's order. Okay. And the greatest thing about peritoneal dialysis, they usually do it at night when this child is asleep. And usually a nurse will come in, or sometimes the parents will just watch it at home. It's put on a machine and they'll do several cycles. They put fluid in, they let it sit, then they let it drain. Then they put more fluid in, let it sit there or still, and then they drain it. And it's 8 to 10 cycles per night, and it works. So, what best describes acute glomerulonephritis? Which one?
B.
Yes, it's after that strep infection. Yes. All right, let's go and let's do our first Kahoot. One second. For Professor Morris's class, I'll be posting the Kahoots and everything and the recording on your announcement, so you'll be getting this pretty quick. Right. Everybody else want to come in? Are you okay? What acid base imbalance may you see with a child that is having profuse vomiting? So, when you're vomiting, what happens? You're vomiting stomach acid, right? What are you left with? Alkaline. So, your metabolic alkalosis, okay? Let me give you diarrhea. Diarrhea is all alkaline. All of the nutrients, the digestive enzymes are alkaline. So when you have diarrhea, you're losing alkaline. What is left? Acidosis. And then respiratory alkalosis will always be hyperventilating. Okay? Now you know all of them. Passage of urine, usually at night, in children who should have voluntary bladder control is called what? And this is called enuresis, okay? This is bedtime wetting. Epispadias is when the penis hole is on top, the urethra comes on top. Hypospadias is when it's on the bottom ventrally, and vesicular ureter reflux is the bladder, urine going back up the ureters into the kidneys, okay? Phimosis, what's that? So phimosis is when the foreskin is tight, it is covering the head of the penis, and you can't pull it down. That's a phimosis. The one that the foreskin is pulled back is a paraphimosis. That's when the penis head swells. Put cool water on it usually, and that's the way we usually can put it back if we're lucky. What is a hydrocele? So hydrocele is hydro is water. It's fluid around the testes. Remember, this usually corrects itself by about 12 months of age. If not, surgery will be needed. A hypospadias is, remember, this is something that we're going to want to have it corrected surgically before potty training. We don't want them squirting urine out of the wrong place, do we? So it's an abnormality on the ventral, on the bottom side. Epispadias is up top, dorsal, and hypospadias is on the bottom, which is ventral side of the penis. Is cryptorchidism. So cryptorchidism is when the testicles don't come into the sac and they're up into the abdominal cavity somewhere. And usually you want to get them corrected by a year old, again, before potty training, because if they stay up in the abdominal cavity, it's too hot and it will kill the testicles and the sperm and become infertile. That's why we want to get them down and why we do check. Remember, one of the questions that as a nurse we should ask parents is if you have ever seen the testicles in the sac, one or two, whichever one. That gives more information. You suspect an infant has a cryptorchidism. How would you examine the child? So, men, when they're warm, testicles sag. When they're cold, they go up to protect the testicles. So, if we want them sagging and we want the testicles as low as they can be, warm the room. As simple as that. Okay. How is a hypospadias corrected? Remember, that is when the urethra doesn't come out the tip of the penis, it comes the dorsal side, the ventral side, and it's the urethra is down there. So, how do you correct that? So, those of you who want to do surgery under local anesthesia, they fillet the penis and open it up. Fillet it completely down and fillet it open. It is general anesthesia. We do need the foreskin because we need to correct where we put in that, making that lumen to put the catheter or a stent in there to hold it open for 7, 10, 14 days postoperatively. Again, our biggest concern is safety of the surgical site postoperatively and no riding bikes and playing with toys that could hurt, that area. What is bladder exstrophy? So bladder exstrophy is when the midline abdomen, when it closes, that bladder got stuck outside. And remember, our biggest concern, anything that's born on the outside of the body, because you're going to hear some more in the GI land, again, it's always protecting the skin, infection control, keeping that area healthy so that we can close it. There will be no delay with it. I've seen quite a few of them actually. What is the priority nursing care for an infant with bladder exstrophy? It just had a storm over my head. If I go off, I'll be back. Just to warn you, it's pretty heavy out there. Again, our biggest thing is all about tissue integrity for the exposed bladder mucosa and preventing infection and keeping it healthy so we can put it back in and let it work. Because again, it's all connected, it's just born on the outside. What are the clinical manifestations of nephrotic syndrome? Remember, nephrotic syndrome has nothing to do with kidney failure. Nothing. So remember, nephrotic syndrome, the kidneys are working just fine, but they don't like protein. So they spit out all the protein in the blood and you become hypoalbuminemia. Remember, you need protein for drug administration. So you become toxic on medications really easy with this syndrome. And of course, the low serum albumin, it's the same thing. And remember, nephrotic syndrome is generalized edema. What are the nursing monitoring in nephrotic syndrome? What do you monitor? Nephrotic syndrome, again, remember, has to do with fluid. Anything that does with fluid, what do you worry about? So we are going to be doing checking the blood pressure because extra fluid, hypertension. We're going to do daily weights. Are you losing weight or gaining weight? Again, intake output, making sure that urine is coming out. And we're going to be monitoring that urine, dipstick, the protein, etc., specific gravities and whatnots. Blood glucose has nothing to do with nephrotic syndrome, okay? I see some of you check that. Children with nephrotic syndrome are often given what medications for fluid overload? Fluid overload, what would you give? Nephrotic syndrome, what is it? It's your loss of protein. How are you going to get that tissue, all the fluid in the tissues back into the blood vessels and urinate it out? Well, you're going to give some albumin. Albumin comes in little bottles, 5%, 25%, and it puts that protein back in the blood system. And then the fluid gets sucked back into the blood system. And then you give a dose about a half hour later of furosemide, Lasix, and you'll see a quick dump of fluids. And that's how we help it. Thiazides are used in blood pressure, mostly. First line. Is used to treat nephrotic syndrome in children. You have a child coming in and they're in a nephrotic crisis. So they're swelling, generalized edema, they've gained weight, their protein levels are on the floor. What are you going to do? And it's just prednisone, steroids. That's what, we treat nephrotic syndrome with. A child is admitted with acute glomerulonephritis. What recent illness could validate this finding? Remember, rheumatic fever, acute glomerulonephritis are both caused by. And it's caused by a strep infection. Those are two things you're going to see on your Hesse NCLEX, acute glomerulonephritis, rheumatic fever, both caused by a strep infection. How did we take care of this? What is the treatment? Long-term antibiotics to treat the strep. A multi. Which findings would you see in a child with a diagnosis of glomerulonephritis? Nephrotic syndrome is generalized edema. Glomerulonephritis is what? You got to remember their differences. So glomerulonephritis has to do with the kidneys. So the kidneys are always worried about hypertension, okay? Which is that headache. Because you are oliguric and you're not having much urine output, you're going to see red, brown, concentrated colored urine. And this one is periorbital edema. Those are some symptoms you need to know. What is the priority nursing care of a child with nephrotic syndrome? Again, when you have anything, diabetes insipidus is fluids, SIADH is fluids, nephrotic syndrome, renal, these are all things with fluid, right? Biggest concern, number one priority, daily weights. Yes, intake and output, but daily weights will tell you, are you gaining or losing fluid? Why is erythropoietin used in chronic kidney failure? So erythropoietin is a drug given sub-Q, and what it does, it increases the production of red blood cells. We use this a lot in conditions where the red blood cells are low. Hemoglobin hematocrits are low. We use this with cancer and leukemias, and especially chronic renal failure because you don't have your own erythropoietin. And what it does, it makes the body produce more red blood cells, and that avoids extra blood transfusions. I mean, if you get one less blood transfusion because erythropoietin is used, that is what our goal is, to make our body work for itself. A multi. Children with chronic kidney disease can have renal osteodystrophy. What can this do to the child? What does osteodystrophy mean? Osteo is a bone. Dystrophy is. So what you're going to see is too high calcium. That's parathyroid, right? Calcium has everything to do with the parathyroid. Your bones are going to be abnormal and you could have some growth retardation. It has nothing to do with uric acid. It's about the bones, osteo, bone, growth. And of course, the calcium is with the bones, vitamin D, all of those things. A diagnostic finding of acute glomerulonephritis may be. So if you didn't know if your child had a sore throat or they were with somebody else, we can do a blood test and we could confirm that they had a strep infection. And it's a positive anti-streptolysin titer, a positive ASO titer. Look at the word strep in there. Strep is telling you you're measuring strep in the blood, and that gives you the positive. Now we know, treat it with long-term antibiotics. What complication of peritoneal dialysis is most important? Peritoneal dialysis. What are you worried about? What are you monitoring for? So again, peritoneal dialysis is a catheter that goes into the peritoneal cavity. You have only one abdomen. Our biggest concern is that we get it infected. So abdominal peritonitis. What would you do if you saw that fluid color change or something didn't look right or redness or tenderness in the abdominal wall? You would call the doctor. And of course, the doctor is going to order antibiotics. Clinical assessment is most important to report with a child diagnosed with an acute kidney trauma. I had a kid, it was like a 9 or 10-year-old boy who was playing tag outside, and he was backwards and ran pretty hard into a trailer hitch into his back. And he came in, his back had this huge bruise on it. And my concern was kidney trauma. What happened was he fractured his kidney. His potassium was, I think, 7.5. Yes, the kidney will recuperate by itself, but we need to monitor the potassium, give stuff to reduce it. And yes, potassium. Remember, kidney, always think potassium. What would you do if the fluid draining from the peritoneal dialysis has changed color and is now cloudy? So you are going to notify the doctor. Again, if it's changed color, the concern of infection is very high, and then we'll have know where to get the urine off that body. So again, notify the doctor and he will order the antibiotics. Die. What should the nurse anticipate for a child who just had a renal biopsy? We stuck the needle into your kidney in your back. What are you going to do? And remember, infants, there's an incision because it's so small we can't find it with just ultrasound. So Bed rest, 24 hours. We're going to look at that dressing. It's a pressure dressing, making sure it's not oozing, and monitor intake and output. And of course, if there's any increased abdominal pain, also. Very good. Last question on this one. What would the nurse provide to an infant that cannot eat normally? If they have a condition where they can't eat, remember growth development infants. How do they soothe themselves? What do they need that they can't eat? And what you're always going to do, we're going to get into the GI system where, like a tracheoesophageal fistula, something where the stomach and the and lungs are all connected and they can't eat. So, what would we give them? We're going to give them that pacifier. They still need that suck. Remember, how do infants, how do young children soothe themselves? It's by their mouths. They explore the world in their mouths and it gives them comfort. Number three, good job. Number two, Dina B. Good job, Dina B. And number one, drum roll, bing, bing. Anaya, good job. Number four, Shelby and Jade. Good job, guys. All right. Let's go back to our PowerPoint. Any questions by anybody about anything so far? As you can see, there's a lot of confusing, which is generalized edema, that was the wrong one, which is, periorbital edema. Those things you have to look for. I'm sorry. This one didn't go down to where I wanted. It's okay. Can you all see a full screen or do you see a half screen? Full screen? Okay. As I said, it's a new computer. I'm not used to it yet, but we'll do our best here. So let's go into GI. Remember, GI is mouth to anus. That's all considered it. So there's going to be mouth things that we're going to talk about, and we're going to talk all the way with things about the anus. So, first thing that we do is we eat, right? And if we're not eating correctly due to many things, cancer, HIV, sickle cell, cystic fibrosis, low birth weight, remember all of these things can interrupt the amount of vitamins, minerals, and stuff that we need. And again, it's a risk for growth failure. So, celiac disease. This is something we eat that causes the body, the small intestines, to cause a lot of pain and discomfort for these children, which become adults. This means you can't have wheat, rye, barley, or oats. Anything with it, they eat. The small intestines goes into severe pain, and again, this we have to avoid it. Rice actually is a good alternative. Rice breads, etc., etc. So, what is celiac disease? It is in the small intestines. And what happens is it has an inability to digest fat. So, what happens when you eat fat? a large amount, you're going to see it in your stool, and it's called stypturia. This stool is very, once you see it, you'll never forget it because it's pale, it's bulky, and it stinks. It's malodorous, like really bad. Now, what is the concern about a child with celiac disease who can't absorb fat? Well, fat is very high in calories. And if we do not give them enough calories in carbohydrates and proteins, they're not going to be gaining weight the way that they should. So, how do we monitor these kids? What are we going to do? Well, it's going to be a low gluten diet, which is no wheat, rye, barley, or oats. It is forever. There's no cure for it. It's just maintenance by diet. And rice is that great alternative, again, and monitoring their heights and their weights. Another thing that can happen, are you seeing the slides change? You're not. Okay. All of a sudden, I realized that one stopped. Or hold on a second. Let me go to another one. So I said, I got a new computer and it's driving me a little crazy. There we go. I did it. Nutritional, celiac. Now the next one. I'm glad I saw that. Again, if you see something crazy, let me know, guys. I don't get upset if you come in and tell me things or ask me questions at all. It doesn't bother me. So, food allergies. This is one of the big things we're worried about children. So, as infants, we know we don't start feeding food until 6 months of age. And the reason is the GI tract does not tolerate these foods, okay? So at 6 months, we'll introduce them one at a time every 4 to 7 days because we don't want an allergy. What would you see with a child with a food allergy? It could be a rash like this picture, or it could be a diaper rash. It could be vomiting, diarrhea, it could be abdominal pain, up to anaphylaxis. Okay? Now, there's also foods that could be an intolerance. We've also heard of lactose intolerance. So that's probably one of the biggest food intolerances that you see. Know that if you have a lactose intolerance, that means it will be avoided. So you've got to be concerned that that child's getting enough vitamin D and calcium. So they might get supplements for it. So any food that they can't eat, look at the nutritional value of it, and then we can give it through vitamins. Now, GI dysfunction. If you're vomiting a lot, you're diarrheaing a lot, constipated, what can happen? Well, if you're spitting up, you're not getting all your calories. So growth failure can be there. It also can be, again, the GI tract, this upset, abdominal pain, distension, GI bleeds, nausea, vomiting, diarrhea. All of these things can be a problem. Now, one of the conditions, there's several conditions that can have a problem with feeding and dysphagia, an inability to eat, or they have a hard time. DeGeorge syndrome is one of them. Pierre-Robin is another one where they have dysfunctional swallowing. So these children, because they can't eat well, are not getting their food. And remember, fever. What happens with a fever? Insensible fluid loss. Remember, dehydration. Big thing. Remember, with fever, we always have to increase fluid to replace the insensible fluid loss. So, dehydration, as I said, very, very dangerous in children, and it can cause kidney failure on it. It's caused by that insensible fluid loss, which could be from that fever. It could be all of a sudden your kidneys are excreting too much. It could be vomiting and diarrhea. Could be ketoacidosis like diabetes, and it could be burns. That's a big one. You take all the tissue in the skin, that can cause it. So there's a big fluid balance that we do give there. So, dehydration, what do you see? If it's an infant, it's so easy. Look at their fontanelle. You could see it actually. I've seen them look like that. That girl on the or boy on the bottom left, do you see the color of the nose and the ears, that paleness? That always will be dehydration. They get pale. Capillary refill is bad. So, adults, children, what do you see? Elevated heart rate, decreased blood pressure, prolonged capillary refill, decreased urinary output. And in infants, sunken fontanelle, crying. These poor children, these babies cry, and there's no tears that come out. I think that's the saddest thing. And also, skin tenting. You can pull their skin up, and it just sits up, usually on their abdominal wall there. So, again, how are we going to treat vomiting? If we are vomiting, there's no way you can give oral fluids. So you need to give them IV fluids. Now, you need to know how bad was that dehydration. I mean, we could see the elevated heart rate, decreased blood pressure, we can see decreased fontanelles, but get a basic metabolic profile. Let's look at those electrolytes, see what's going on, and then we can work from there to correct it back to where it needs to go. We will give fluid bolus. Be careful. No potassium, no dextrose can be given in a bolus. You can give ringers, you can give normal saline, but again, no potassium and no dextrose. When we want to add potassium to the IV, remember this kid's dehydrated. They probably not going to urinate for a while. So you cannot give them any potassium until they void or until you get that potassium level from, the laboratory. Of course, we're going to give an antiemetic. Zofran, Odonstron is one that we give all the time, whether oral or IV, we give it depending. So you've got a child who's dehydrated, and we admitted him to the hospital. How do you know that your interventions worked? Well, what did I tell you about fluid? What's the big thing that we monitor? Anything with fluid is daily weights, right? So the weight from admission in the ER and the one weight in the morning on discharge, you should see an increase in weight because now they've gained that fluid back. So looking at weights can tell you a lot of information. So measuring INO, there's all different ways, and depending on it, we know urine, vomit, actually profuse sweating. If we needed to, we could somehow get a estimate of that sweating. But I think vital signs, increased heart rate, decreased blood pressure, those things you'll see with the skin turgor, and of course body weight, intake, output, body weights. And fontanelles in children, they'll be sunken. At rest, they'll be sunken. Crying, it will still be sunken. And as they get older, you're going to see their mentation is going to be decreased. Now, babies can have diarrhea. It could be acute, it could be an infection, or it could just be, we don't know. This kid just has diarrhea. How do you treat diarrhea? Well, they can drink because they're not vomiting. So we're going to be replacing those fluids, right? We're going to be losing all of our alkaline. So we're going to go into metabolic acidosis if we don't replace the fluid. So oral rehydration therapy is number one if they're not vomiting. If they're vomiting and diarrhea, it'll be IV fluids, okay? And we're going to be introducing the diet. These children, if you just keep them on fluids, how are you going to solid up that stool? There's nothing there to make a good solid stool. So start diet. And of course, it's a bland diet. Start slowly. Constipation in children is very common. Actually, I remember one student's little daughter, when I was working on campus, she was complaining of, constipation, abdominal pain, and It's something that children can hold their stool due to psychological stress that they're going on. Now, it could be that they had to move, or mommy, daddy getting divorced, or their best friend left, or their cat died. I mean, it could be anything. They want attention, right? I have seen children hold their stools up to 10 days. And it was evident because he did a abdominal x-ray and it was the whole x-ray was full of it. This is the only time that you would give an enema. You do not ever give regular enemas to children because by the time they become an adult, they're going to need dynamite in order to get that stool out. So we don't. The only thing we might give is a little Metamucil, right? Something to that type of stuff to get the stool going, and of course, diet. Now, important concept here. Your baby is born and you don't see any stool for the first 24 to 36 hours. That's not normal. Usually children come out and that black, sticky, green looking stool that's a meconium looking stool. If they don't have that, it's unusual. So there are certain conditions and you need to know this. It could be an intestinal atresia stenosis. That means structural, something's going on. It could be Hirschsprung's disease. We're going to go into that in a second. Hypothyroidism and cystic fibrosis. So we'll be checking a sweat test. We'll be checking the thyroid hormones and we'll be doing an x-ray. Important that we do those things. So constipation during infancy, usually breastfed babies, they have a lot of stools. That just seems to be. It seems to be that babies that are given formula tend to have less stools. They tend to be more solid than would be the breastfed baby. Older children, how do we help with constipation? And we know it's with diet, it's giving them whole grains. I put black beans in there because I live in South Florida with a lot of Hispanic, and that's actually one of the things that can help constipation and keep the stool moving in children. Now, enterobiasis. This is worms, pinworms. There's roundworms, there's pinworms, and these are usually due to children outside playing in the dirt. Their nails are too long, dirt gets underneath, and what do children do? They put their hands in their mouth, they eat the eggs, they swallow them, and they come out the rectum. And it's intense, intense rectal itching and scratching, mostly at night. So they're not sleeping well at night. So you need to collect the worms to show the doctor. How do we do that? Well, we take a flashlight and a piece of scotch tape. We go in at night. We open up the buttocks, see the anus, put the scotch tape on it, pull it up, and hopefully we get a little worm. They're tiny, tiny, tiny. Usually, if a children in the house has it, the whole family should be checked if they have these pinworms. Enterobiasis is pinworms. Peptic ulcer disease, we treat just like adults. Children do have peptic ulcers. They're little worriers, some of them. I've never seen a surgical outcome where we'd have to do gastrectomy, partial gastrectomy. No, usually it's putting them on medications. It used to be Zantac, now it's Pepcid, famotidine, something, and of course, diet. Now, liver problems. Children can be from virus, non-viral, could be autoimmune, could be anything. Now, children who have problem with their liver, what do we have to be concerned about? Well, what does the liver do? The liver secretes bile into the small intestines, and its job is to digest fat. So if you do not have bile going into the small intestines to help with digestion of fat, you are just going to lose it. It's going to grease. It's going to come out the other end. Okay. So again, just like celiac disease, high protein, high carbohydrates in order to try to give those extra calories that they need. And fat causes gas. So we want these children on a low fat diet. Another thing with the liver is something called biliary atresia. First diagnosis you see is jaundice. Usually in the eyes we start. Biliary atresia is when the liver is not connected to the common bile duct and you're not getting any bile going anywhere but into the blood system and you're turning yellow. And of course, you're not treating that fat because you have nothing to digest it. Again, it needs surgical intervention. Hirschsprung's disease. Now, we call this congenital aganglionic megacolon. What it is the descending colon doesn't have any nerves or ganglion cells. It's called an absence of ganglion cells. There's no nerves. So if you don't have any nerves, there's no peristalsis to get that stool out the rectum, okay? So it gets bigger and bigger and bigger and bigger. And it doesn't hurt because there's no nerves. So at birth, you would have a child that does not have stools or maybe might have a little bit of ribbon stools coming out that little tiny little rectum. A little bit could squeeze out. Ribbon-like stools are a symptom of Hirschsprung's, okay? It looks like a icing thing when you put it on a cake, that little ribbon that comes out there. You would see a distended abdomen, but again, it doesn't hurt. So we usually find these at birth, sometimes later on when there's periods of constipation. They think constipation is just that this being obstructed. So usually we will see it at birth, no stool. And of course, we'll do an x-ray, a barium enema. We'll do a rectal biopsy. We want to see if there's nerves in the cells there. So how do we correct Hirschsprung's? You've got dead, unusable, well, not dead, it's alive, but it doesn't move. There's no nerves in the intestines, so it's non-functional. That piece of intestines has to be removed. Sometimes we have to put the end up and make a colostomy. And other times we can attach it. And we call that a pull-through procedure. And that will pull the intestines down and there's never a break and you never have a bag, a colostomy. Usually Hirschsprung's disease, by 1 year old, if they had to put a colostomy, they can reconnect it. That's usually the goal, again, before potty training. Acute appendicitis, just like adults. Just like adults, same treatment. So what is it? Well, acute appendicitis, right lower quadrant, McBurney point, rebound tenderness, all of that. Children are interesting. I can see an appendix walking down into their room. They have their hand on their right lower quadrant and they're bent over a little bit and they limp on their right leg. You know that's an appendix. So when we decide and we think this is appendix, we're going to make immediately NPO. Stop them eating. It's a surgical intervention. We're going to send them for an ultrasound, and it's going to show the appendix is needing to come out. At that point, we'll start IV fluids, and again, of course, they're NPO, and because it's an itis, an inflammation, an infection, we will give pre-op antibiotics. If there's any meds that child needs, you can give them their pre-op meds. Again, just check those with the physician if they can have them. So they went up to the OR and the appendix, oh my goodness, it burst already. The thing, if an appendix bursts before they go to the OR, all of a sudden their pain is gone. That's what you see. They hurt like crazy when the appendix is there and we can get it out without it already bursting and causing peritonitis. But pain stops, you know the clue. It's going to be a ruptured appendix, and it's going to be causing peritonitis or an infection in the peritoneal cavity. How do we treat this kid with this post-operative care? Well, these children's intestines have been hit with all of the debris from the appendix, which is all infectious. The intestines are angry and they're not happy because they've been irritated bad. We need to let the intestines rest. So NPO, IV fluids, and an NG tube because we want not anything, no stomach acid as or minimal going down into that lower GI tract. Okay. We will be given antibiotics and we'll be monitoring the lab values. Is that white blood cell coming down? Okay. We will be looking at that, the incision site. Because the inside was all infected, when they close it, they call that it's a contaminated or infected closure. The chances for that to dehisce are great. So always check the wound, the surgical site, because I've seen one dehisce. It will happen. So that we have to be careful with. Post-operative care, any child. Number one, make sure they're on good pain control. Many of them don't know they can ask, so make sure you get them their pain medicine. They can be up, out of bed, ambulate, not 2 times a day, as many times a day as they can. And children with their blowing bubbles and or blowing a pinwheel, you're giving that, and they're taking deep breaths. I used to, because I worked night shift, I would have the older kids get a straw and do spitballs. And it used to do that extra peep. I never had a problem with respiratory with these patients because we used to have fun at night. I went to work and played every day, I call it. This is an omphalocele, gastroschisis. These are the insides born on the outside, okay? This is not a bladder. This is the stomach or part of the stomach area, okay? So what is our treatment? Well, they can't be fed because their stomach's on the outside. We're going to be needing surgery. And our biggest priority is to cover that area with a moist, sterile, normal saline dressing. And again, keeping the skin integrity good. We are going to be putting this child on antibiotics, preventative, IV fluids, and they cannot be covered up. They can't be swaddled. You have to monitor their abdominal thing that's sticking out of them. So on a warmer so that they can get the proper heat. Okay. These kids actually do well. The surgeon comes in and stretches it and pushes it in a little bit day by day, and eventually they can close it up. Now, intussusception. This is an interesting one of the diagnoses. These are common in your toddlers mostly. I've only seen one 5-month-old who had it, but usually it's like 1 to 3. That 2-year-old is the big one. And the first time I saw it, was a toddler in the mother's arms, screaming, kicking, and yelling. And I touched the abdomen and it was tense. What happens is the intestines suck up into each other. It like a telescope, and it causes swelling and intense pain. What we do is we try to get an ultrasound to find it. The other thing I do is I check their diaper or their underwear. You might see current jelly that pushed it out the rectum. Okay. If it sucks into each other, it pushed it out the rectum. Current jelly with maybe some blood streaks in it. So after we do the ultrasound and we find we have it, many kids don't need anything. All of a sudden, the pain is gone and they're running around. And we'll send them home on high fiber diet to try to keep the intestines open, telling them if they need to come back, they can, if it happens again. They also, I've seen this done a few times where the intestines are sucked in, where they do an air enema in radiology with the radiologist under fluoroscopy. And they put a hose up the rectum and they pump air and it pops open that intestines and the pain is gone. Okay. Usually that works. I've only seen one have to go to the OR and have a piece of the intestines removed, and that's usually what it is. A Meckel diverticulum. This is in the small intestines, and it's a little piece of tissue that sticks out and it rips. The problem with it, the tissue in there in the intestines is highly vascular, right? Small intestines, what does it do? It absorbs all the food, all the nutrients. So this little tab that comes out has a big blood vessel in it. And if it rips and tears, it's not really painful, but it's going to bleed and you're going to see red blood coming out the rectum in the toilet. That's what you'll see with them. They go and they do this x-ray procedure, this radionuclide thing. They find it, they go in, they do surgery, and they do well. IBS. IBS is ulcerative colitis. This is Crohn's disease. This is something with the intestines. They're inflamed, causing pain. A lot of times they have a lot of diarrhea. Usually, diet can help them. Sometimes medical treatment. Some of these Crohn's disease are placed on biologics so that the inflammation can be decreased. But again, that's usually what happens. Sometimes a piece of that intestines is so inflamed they have to remove it. So that can happen. But our big thing is nutritional support on these children, preventing them having these symptoms. Now, short bowel syndrome. This is when a piece of the intestines has to be removed and you're left with a very short piece. I'll tell you a story. I had a little girl, she was a triplet, and she was a cardiac child. And she came in for her second stage from a hypoplastic left heart syndrome. Postoperatively, she had a rough course, and they were feeding her with a nasoduodenal tube a little bit just to keep the intestines going. Her intestines didn't like it. And what happened is she went into something called necrotizing enterocolitis, NEC. And what it is a piece of the bowel dies. Happens a lot in premature infants, and it's something why we do abdominal circumferences before they eat all the time. So, in this case of Jessica, she belly blew up. They sent her to the OR, and 48 centimeters of her small intestines had to be removed. I mean, some incredible big number. She had a very short small intestines left. So she had a very short area to absorb nutrition. So what is our big concern with short bowel syndrome? Nutrition. They're not absorbing. If you see this child, they have a Broviac. They usually get a Broviac at night with a hyperal and lipids. They also have a gastrostomy tube, and we will give feedings there. We're trying to give the most nutritional support that we can. And that gastroschisis is like the omphalocele. Again, it's so that something born on the outside of the body. Hernias. We get all sorts of hernias. Older people get inguinal hernias. Babies get, I call them umbilical hernias. That picture there, if you can take your finger and smush it in and out, it's soft and squishy, you're good. If it suddenly becomes hard and tender and painful, this is what we call an incarcerated or a strangulated hernia. And the only treatment is surgery. So you get a child who has, let's say, an umbilical hernia that's all of a sudden in severe pain. Stop eating, send them to medical care, send them to the hospital. They have to have surgery, or that piece of intestines will die. Anorectal malformations. Do you know you can be born without an anus? So sometimes, in my career, I never saw it. I have seen different sort of fistulas where we have urine coming out of the bowel, and I've had stool coming out of the vagina. I mean, all different things. Usually the nurse is the one who finds it. It's like it's coming from the wrong place. And then, of course, you do the surgery and you try to correct it. The imperforated anus, remember, you don't have an anus, you're not going to do rectal temps. And if they've had surgery, you're still not going to do rectal temps because we're just going to do axillary temps on these. Children put everything in their mouth, don't they? And one of the things they put in their mouths are things that they shouldn't have, right? They are going to put the most common of all things that children take that I've seen is actually their vitamins. They like their Flintstone vitamins, and all of a sudden they come in, yeah, they ate half a jar. What would you tell a parent who all of a sudden they see that the bottle of whatever is missing and they see it in the child's mouth? What do? We do not give Epicac. We do not induce vomiting. We call poison control before anything. So every parent should have the number of poison control. They will tell you what to do if you need to do something now, when they drink some milk, a piece of bread, or nothing. Get into that closest ER as quick as you can, okay? We know that lead poisoning is out there. Kids chew on things. We know that if they have, for instance, windowsills, it's what kids like to come up and look out the window, right? And they bite on it. It's an old building. I mean, they're not as many as there used to be, but again, it still can happen. Chelation therapy, just like we would use for thalassemia. Chelation therapy, get rid of the lead, whether it's oral med or the apheresis machine. Okay, let's go into vomiting. Vomiting is just coming out of the mouth, and there's all different types, and we're going to go into those things. What do we do if a kid is vomiting a lot? Well, what's our biggest concern with children? Dehydration. So we are going to draw a metabolic profile. Let's get a beginning. Let's see what we're starting at. And again, we're going to start bolusing that child with normal saline. Again, never with potassium, never with dextrose. We don't do that. And then we keep that child NPO and give them some oral, some IV anti-emetic drug, Donstron, Zofran. And of course, you're not going to feed this child until the vomiting stops. Gastroesophageal reflux, GERD, very common in children. These are children that are every feed spit up a little bit. The problem is they're spitting up. They're losing calories, which means what are our concerns? Our concern is that they're not gaining weight, and you need to feed the tank for cognition. So if we see them having these small vomiting after each feed, we need to do something. We need to keep that food down in there. So we can thicken their feeds with rice cereal, even as a newborn. And then you say, well, you're not supposed to feed a kid because their GI tract is not mature enough. Well, that little bit of rice cereal keeps the milk down. So they're getting more nutrition Even if the rice cereal, they don't use it and it comes out the rectum, they're still getting the nutrition of the milk. And that's why they put it in there. The other things is, how do we feed the child? Number one, you don't overfeed a baby. Must be burped well. And after it, they need to sit up for a good half an hour so they cannot reflux because it burns. It's going to burn up their esophagus. Older children that have reflux, you're going to see them with this chronic cough. When we talk about mini aspirations, right? That's that little cough. And they could have that burning because that esophagus burns. So you would see that in older children. In infants, you'll just see that little spit up after each feed. One of the things that we can do to this chronic kid who's burning up the esophagus, and we need to do something, is we can do something called a Nissen fundoplication. We use this a lot with anybody getting a gastrostomy tube. We do a Nissen fundoplication so they can't vomit. It takes the stomach and flaps it over on the esophagus so it can't get up the esophagus. So now when we're feeding these children, they can't vomit. And that's what we want. That's a Nissen fundoplication. Now, a common condition of children, young kids, I call it 3 weeks to 3 months old. It is where the pyloric sphincter, which is where the stomach empties into the small intestines, is hypertrophic. It's narrowed. No milk can go down. So what happens? The baby eats and drinks. And is happy. And all of a sudden, this child vomits, but not this little dribble. It is across the room. I've had children, little 6, 7 week old babies, where I could hold them up 10 feet from a garbage can and they're vomiting and they're going to projectile and they're going to hit that garbage can. I mean, it's like The Exorcist. It is forceful. So if we see a child, an infant, that age, and they're coming in with vomiting, my first question, how are they vomiting? Is it a dribble or is it across the room? And then I know what to do. A dribble is GERD, it's reflux. Across the room is hypertrophic pyloric stenosis. Once they tell me it's forceful vomiting, I'm going to take my hand and put it underneath the rib cage, right in the middle, a little bit to the right, and I'm going to feel. It's like a marble, an olive. You can actually feel the hypertrophic pyloric sphincter there. You really can. So we have figured out they have pyloric stenosis, make them NPO. They're going to go for ultrasound. We're going to confirm it. And then they're going to go for the OR. Now, what are you going to do to prepare for the OR? Infants do not tolerate being NPO for a long period of time. So we're going to start them on, of course, NPO because we don't want them vomiting again because they'll just continue to vomit. We're going to give them IV fluids. And that is because they need that dextrose and stuff. It'll be regular fluids, D5.2, normal saline, 0.3, whatever the doctor orders. And then post-operatively, that sphincter is now open. So now we need to test it. Does it work? Now we're going to give clear liquids and start it. And they consider actually breast milk clear liquids. So GI, mouth to anus. So what can happen with the mouth? It could be a cleft lip, cleft palate. A cleft lip, you could be one side, both sides, and we need to do something because how can you eat if you can't wrap your lips around a nipple or around a bottle? And you can't suck, you can't make that suck there. So we try to do the lip. We do the surgical repair at 2 to 3 months. We want that lip to be there, okay? That little metal thing that's sitting there is called a Logan bar. And that's if they put their face into the blanket, the bed, it's not going to rip open that plastic procedure they've done to close it up. Those are the cleft lip palates. I've seen one, I've seen two, an end palate. I've seen all of them. So the palate, the lip is done at 2 to 3 months. The palate is not done till 6 to 12 months. Our biggest concern is to get that done before they really start talking. Because if they don't have a seal on the palate, they won't talk like that. They cannot pronunciate. So it does affect speech. Many of these children with cleft palate will go to speech therapy because of that to try to help them speak well. As I said, our biggest concern is eating. They have no lip, they can't suck. They have no palate, they're going to aspirate. So there's all sorts of things that we can do. Do you see that bottle down there, that little plastic that comes up? That's very soft. So when you turn the bottle over, it fills that little area with milk. And as the child, as you're holding them up tall, you squeeze it slowly and it drips a little milk into their throat and they can eat and get that feeling of I'm sucking, swallowing, and eating. We know this is going to tire these kids out. To breastfeed them, this mother has to be a saint because she has to squeeze her breasts as she is breastfeeding. Some of them will pump and then put it in the bottle, and that can help. Again, our biggest concern is they're not getting enough. And again, that will be growth failure. So, esophageal atresia and tracheoesophageal fistula. This is something I mentioned where you're going to need a pacifier for. Esophageal atresia. Remember atresia, A means without. That means the esophagus does not attach to the stomach. So it just sits there. So if you eat, it's going to come back up. So you do not want to feed that child. Another thing that can happen sometimes with, sometimes separately, is something called a tracheal esophageal fistula. So, what is that? It's the trach. So, your trach is connected to your esophagus. There's a tube or a fistula. So, if you eat the foods or milk, it's going to go across the fistula into the lungs. Our biggest concern is aspiration. Okay. What will these children look like? They're going to be gagging and coughing. And because they can't get their breath, they can become cyanotic. What do you want for these children? How are you going to maintain these kids? Well, you need to keep the airway open and prevent aspiration pneumonia, which means you're not going to feed them. You will have them do surgery, but sometimes they don't do it right away, depending on the child, the condition, other conditions with them. These children are normal mentally, whatnot. It's just they're not connected. I have seen one with cardiac condition with esophageal, transesophageal fistula. I've seen that. And they had to wait for the cardiac to be fixed before, but usually they do it pretty quickly. So, preoperatively, before we do surgery and connect everything and take out that fistula if that's what's there, keep the head of the bed elevated, right? You want them to breathe good. You want to keep their mouth clean, so suction their mouth, keeping all of that extra mucus away. Nothing in the mouth except your little pacifier. No drops of sugar water, no nothing. Keep it empty, or else it's going to go directly down into the lungs. And we're going to have them on IV fluids, and because they still swallow their own spit and they're still going to be having little mini aspirations, we're going to be giving antibiotics pre-op. Pyloric stenosis, we don't need antibiotics. You're not aspirating. The tracheoesophageal fistula, you need antibiotics because you have aspirations. Okay, let's go to our next coat. Catherine, could you come on camera for me, please? Thank you, my dear. So a lot of different diagnoses you've never seen, isn't it? Kids are interesting. You really have to think when they come in. Who's going to be an Anaya this time? Come on, guys. You got to join me. Okay, thank you, guys. Gastrointestinal dysfunction. Multi. All of the following are symptoms of dehydration in an infant. And I tell you, the only difference between dehydration in an infant and an adult is a fontanelle that's depressed. So you have pale skin, you have loss of that skin tenting, that loss of elasticity, weakness, lethargic, decreased urinary output, tachycardia, decreased blood pressure, decreased mentation. These are all the same in adults or children. Infants will just show you their fontanelle. What is priority treatment for a child with dehydration due to profuse vomiting? How do you treat profuse vomiting? So remember, dehydration can be treated orally or IV. If you're vomiting, you don't want to give them more to vomit. You're going to give it IV. If you're diarrhea, you're going to give food and you're going to give oral stuff. So again, that's a concept you need to know. A multi. What physical assessment of dehydration might you see in an infant? In crying with no tears. Poor little guy. It used to be the saddest thing for me to watch. An infant crying and there's just no tears. And the one thing I didn't mention is yes, their eyes also sunk in. So skin tenting, the fontanelle is sunken, and then the eyes actually sink and no tears. And it would be pale cheeks. It'd be pale color. A multi. What type of IV fluids would you bolus for a child with severe dehydration? And these are fluids, severe dehydration, adults or children, it doesn't matter. This is the way you bolus fluids. And it is only no potassium, no dextrose. You only want normal saline or Ringer's lactate. If you notice the one, D5.9, that's dextrose. No. Zero point 0.9 normal saline with potassium? No. It's only saline Ringers. No potassium, no dextrose. That's a very important concept. Multi. What lab tests can confirm a diagnosis of dehydration? So you're going to do a basic metabolic profile. That's always you're going to do. A urinalysis can show you what specific gravity is, elevated, and of course kidney function, BUN, creatinine. Those will tell you also. Liver has nothing to do with dehydration. What is the treatment for an infant with diarrhea lasting for 4 days? So remember, it's oral electrolyte fluids, whether Pedialyte, Gatorade, Powerade. As long as they're not vomiting, you can introduce orally. Sometimes we do IV with oral, but the concept here is diarrhea. You can give oral electrolyte solutions, and water does nothing. What acid base imbalance might you see with a child that's having profuse diarrhea? Remember, diarrhea, you are losing all your alkaline because that's all your digestive enzymes. So, what are you left with? Metabolic acidosis. Remember, acid is in the stomach. You get rid of vomiting is metabolic alkalosis because the acid is gone. It's opposite for diarrhea. All of the digestive enzymes are alkaline. So you're getting rid of alkaline. What is left? Acid. So metabolic acidosis. There was one HESI that had four acid-based questions on, and that's why I put these here. And I know you see it in MedSurge. A multi. And if an infant has not passed the meconium stool in the first 24 to 36 hours, what would you assess for? So electrolytes have nothing to do with not passing a stool, okay? It is either your thyroid's not working, cystic fibrosis, or Hirschsprung's, which is a obstruction. Those three things you see all over in many questions. That's an important concept you need to know. A deficiency of vitamin D causes what? What does D help form? And deficiency of vitamin D is rickets. Scurvy is vitamin C. Proper hepatitis dietary education includes all but what? Hepatitis. What can they eat? Remember hepatitis, that liver secretes bile, which digests fat. So if you can't digest fat, what would you not give that child? Fat. You're going to give them high carbs, high calorie, high protein. That's the answer. Okay. Very similar to celiac disease, very similar to cystic fibrosis. Same thing, high carb, high calorie, high protein, low fat. A multi. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? Now this child has vomiting and diarrhea. What are you going to give them? What are you going to do? So if they're profusely vomiting, you're not going to give anything by mouth. Okay. because it's just going to make them vomit more. So you're going to do that basic metabolic profile. So you have your beginning numbers and you're going to be giving IV fluids. Multi. What nursing management would you anticipate for a child with a ruptured appendix post-operatively? Post-op care for an appendectomy that ruptured. So, any post op care, you're not going to want a child or an adult to be on complete bed rest. This child needs to be up, out of bed, ambulating, coughing, deep breathing, keeping pulmonary care, and preventing any other complications because it was an infection. The appendix burst and it's all raging in the abdominal cavity. IV antibiotics. And we're going to put on NG tube suction to keep the intestines without anything in it. We need it to rest. It's angry at this time. And because you close a dirty wound together, assess that surgical site, the sutures. And again, I've told you, I've seen one dehiscemy. A multi. Which finding in a newborn would lead you to suspect cystic fibrosis? I, I think I worded that question wrong. Actually, those are all things that are due to no stool. That question's written wrong. I apologize. A multi. What is Hirschsprung's disease? So Hirschsprung's is when there are no nerve cells, so there's no ganglion cells, which is another word for nerves, and there's no peristalsis, and it just gets big. And we call that a congenital aganglionic megacolon. That means at birth, there's no nerves, and it stops up in there. And of course, it's the absence of those cells. Has nothing to do with the other two. A multi. When teaching parents about Hirschsprung's disease, the nurse would include what? So you find out your child has Hirschsprung's disease. So Hirschsprung's, because you can't pass the stool, there's no nerves, there's no peristalsis, it causes a megacolon, a bowel obstruction. So we're going to do a two-stage surgery or a pull-through surgery or a colostomy. Either or can be done there. And then, of course, as we post-operatively, we're going to monitor, of course, those bowel habits, making sure that that stool is moving. It's going to be always. We do not treat children with laxatives and enemas. As I said, that is only constipation, severe constipation, and we would give one enema just to get it moving. We would not give it at all the time. Miralax is a great one that we can use in children that just helps. It gives it fiber to that child. What type of stools would an infant with Hirschsprung's disease have? Where's that big dilated colon, and then the rectum gets really tiny, and it can't get through, or some gets through a little bit. And it's called ribbon-shaped stools. Think about the picture, that big Hirschsprung outpatch and that tiny little tube that goes to the rectum. And if something gets through, it's like going through a frosting. It's a ribbon-shaped type stool, which is a condition that occurs mainly in children when the intestines telescope into itself, sucks in, and causes sudden onset of severe pain. And there is intussusception. As I said, if we see intussusception, what am I going to check? Well, it's that kid is screaming, and I'm telling you, arms and legs, and they're unconsolable. You can't console them at all. And I touch their abdomen, and I can feel it tense, and I'm going to look at their diaper or into their underwear, and you're going to see current jelly, maybe a little bit of blood streak in it. A multi. A 2-month-old infant has GERD and has been treated by thickening the formula. How do you know that it is working? So we thicken the formula so they stop vomiting, right? What else do you know? So you're going to see a child that's not spitting up or less regurgitation, and because they're eating and it's keeping down, they're gaining weight properly. How did how can you decrease the incidence of enterobiasis in children? What's enterobias? It's pinworm. How do you get pinworms, roundworms? The whole thing is just keep their fingernails short because everything goes in their mouth. And if they're outside playing in the dirt and whatnot, there are eggs out there. They go underneath the nails, they put it in their mouth, and they go inside and they hatch. And it's intense perianal itching. What are signs and symptoms of enterobiasis? And it's usually at night. And it's intense rectal itching, perianal itching, and it's at night. And again, that's why we take the specimen at night. Gastroesophageal reflux disease, GERD. What's that? So, GERD is when the stomach doesn't hold the formula, the milk down, and it goes up into the esophagus. Would the nurse be looking for when a patient has Meckel, diverticulum? Remember, that's that little skin tab in the small intestines. And we know most of the absorption of nutrients is going to be occurring in that small intestines because that's where all those enzymes are secreted. And it's painless rectal bleeding. Oh, we got a blooding. A 6-year-old child goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment is priority? What do you need to know about this child? I worked a lot in the emergency room the last 10 years of my career, and we used to get a lot of children in with abdominal pain. And it's very important. Where is it? Many times it's umbilicus, but if it's right lower quadrant, we know it is a surgical emergency. So we need to know, where is that pain? That's a very important concept. Where is the pain? Now I know what to do for you. What would the nurse expect to see in an infant with biliary atresia? Atresia without biliary, liver. Liver is not connected, small intestines. Liver not secreting bile. Fat can't be used. What are you going to see? That's how you have to think of it. So clay colored stools, and because of the fat, you can have a distended abdomen. Very good. A lot of gas. What structure of the mouth can be impacted by cleft lip and palate? And that is hard palate, soft palate, lip. It's the whole thing. Again, do you know when you're supposed to do surgical repair? Cliff lip repair is typically done when? The lip. When do you do the lip? And that set bottle I was talking about, actually, a mother developed that many years ago. It's between 2 to 3 months because we want to get it as quick as we can so that infant can put their lips around a bottle and at least try to attempt that suck. If they don't have a palate, it will work at that point and they'll be able to feed themselves. When does a cleft palate repair typically occur? So we did the lip at 2 to 3 months. When are we going to do the palate? What is affected if the palate's not repaired? Speech. So then, when are you going to do it? At 6 to 12 months before they start talking, because they're going to have issues with speech no matter what with that palate. Esophageal atresia. Remember, A is without. We have stenosis, we have atresia. A is without, no opening. Stenosis is narrowing. And that's the lack of an opening from the esophagus to the stomach. It's not connected. So, what is our treatment going to be? Well, NPO, because we don't want it to go down and come back up. Chances of aspiration can occur, but we don't want to have all of that vomiting going on. This is a child that would be treated with IV, antibiotic, and a pacifier. A multi. Neonate with a suspected tracheoesophageal fistula, nursing care should include, we've got a tube connecting the trachea and the esophagus. What is your concern here? So if I have a connection between my esophagus and the trachea, if I drink anything, even my saliva, it's going to go across the fistula and it's going to aspirate. And I'm going to have many, many aspirations. And we don't want that. So this child, elevate the head of the bed, NPO. We're going to have suction at the bedside. And because the chances just swallowing their own spit, they are having mini aspirations, we'll give antibiotics to prevent prophylactically so we don't get a pneumonia from these mini aspirations that are going on. What are the classic signs of esophageal atresia and tracheoesophageal fistula? So when you have this fistula, and with your own spit, you're still going to be having mini aspiration. So you're going to see that cyanosis, choking, and coughing. An olive-shaped mass in the right upper quadrant, and vomiting, that's pyloric stenosis. Current jelly stools is intussusception, okay? What is Nissan fundoplication? So a Nissan fundoplication is done to prevent vomiting. So it's a surgical treatment that we take the stomach and we attach it to the esophagus so food can't come up. So we prevent that reflux going on. We use it for GERD. We also use it when we put in gastrostomy tubes because we're giving a big bolus of fluid and we don't want it to come up. So it's usually a gastrostomy tube with a fundoplication 99% of the time. A 5-year-old child is complaining of epigastric pain and a persistent cough. What would you suspect? And this is reflux. This is GERD on an older child. And they have that burning coming up. It's that reflux going up and down, mini aspirations. It's the cough. And of course, the pain is that burning in the esophagus. What is ranitidine used for with a child with peptic ulcer disease? Or famotidine? What do we treat peptic ulcer disease for? And when we're giving this, it's for gastric acid production. We want to reduce it so that we're not having all the burning and then, of course, eating the lining of the stomach. So it reduces gastric acid. What should nurses monitor to assess the effectiveness of GERD treatment in infants? If I'm having reflux, how do you know the treatment you did is effective? You're going to see that they're eating and they're gaining weight and they're not vomiting. Very good. A congenital abnormality where the abdominal contents come through the abdomen in a sac. And that's called an omphalocele. Sometimes you see the stomach, and that's a gastroschisis. And of course, you have the bladder and bladder exstrophy. These are all congenital things because the closure was on the outside, it didn't close correctly. Signs and symptoms of hypertrophic pyloric stenosis. So, hypertrophic pyloric stenosis is projectile vomiting because the pyloric um, valve at the end of the stomach into the small intestines is really narrowed and food can't go down. So all of a sudden they just vomit projectile. They have a great appetite because once they vomit, they're so hungry, they want to eat again, but they can't get it down. That's why they keep eating and vomiting, trying to get the food in them. And they're crying, I'm still hungry, I'm still hungry. Signs and symptoms of hypertrophic pyloric stenosis. So as I get my assessment on my infant, ages 3 weeks to 3 months, and they're telling me they're vomiting, and I ask, is it dribble or across the room? That's what I want to know. The second thing I'm going to do when they say across the room, I'm going to put the hand underneath in the right upper quadrant, and I'm going to feel an olive or a marble. It's like that little round. It's hard. You feel it. And they're hungry. They want food, but they're not getting it. Preoperative treatment of pyloric stenosis includes so pyloric stenosis is just a feeding problem. It's structural. Food don't go down. So just keep them MPO, and because they're infants, they need IV fluids. Remember tracheoesophageal fistula, your esophageal atresia. There's these mini aspirations. That preoperative treatment's going to include antibiotics. That's the difference. Students get confused with that. This one has no aspirations, so you don't need to give prophylactic antibiotics. What does celiac disease affect? Wheat, rye, barley, and oats. And we're concerned about fat digestion. Again, it is the small intestines. I put this out every term, and there's still some students who think it's a different part. So good job, guys. If you have celiac disease, what should you eliminate from your diet? So wheat, rye, barley, oats. What's a good alternative? Rice. Okay, remember that. Priority nursing care of a child with a ruptured appendix post-operatively. Priority nursing care. What's your biggest concern when an appendix has ruptured? I mean, any of these could be an answer, right? But what's your priority? Antibiotics. Remember, huge infection going on. So that is your priority. A multi. How can you assess the effectiveness of fluid replacement for a child with severe dehydration? A little bit of everything, isn't it? Because what shows dehydration? Elevated heart rate, decreased blood pressure. Your weight is definitely going to tell you, are you gaining it from that loss of fluids, capillary refill, looking at the skin tenting, the level of consciousness, all of these things. Infants, you're going to see Fontenelle's not depressed. They're crying with tears. Their eyes aren't sunken. Again, it's so many things it could be. A multi. Vitamins that children with celiac disease are prone to lose are What do you know about celiac disease? They have fat intolerance, right? They lose it. They have steatorrhea, malodorous, just bulky. And I'm telling you, it stinks. So they're losing all of their fat vitamins. So they're going to need replacements. Vitamin C is a water soluble one, to let you know. What foods would you select for a child with celiac disease? Celiac disease, no wheat, rye, barley, oats. Which of those don't have all that? That's your answer. And that's the bacon. You have eggs, you can have dairy, you can have fruit, vegetables, but fish sticks, macaroni has, pasta in it, and that is, some sort of flour. Toast, again, garlic bread. These are all things they cannot eat unless it's rice flours. And last question. What would the nurse provide to an infant that cannot eat normally? So remember, an infant, one of the things that they do need because they comfort themselves, it's part of what they need for growth and development, is that non-nutritive sucking device or a pacifier. Good job, guys. Number three, drum roll, me. Oh, I did good. Two, Dina. Good job, Dina. Number one, Vicky. Oh, good job, Vicky. And there she is, Anaya and Shelby. Good job, Anaya. You did a great job today. So remember, you have that big project that's due. Make sure that if you haven't already, tell me or Professor Morris what subject you want it on. Know that next week you're having a quiz on this information. And if you've listened to me, you're going to be just fine on that quiz, okay? Anybody have any questions about anything?
Yes, where is that case study you talking about that's due? The third one.
We have the case study on abdominal.
Oh, you talking about the sim chart.
Yeah.
Oh, okay. Thank you.
Well, this is what they wrote on the syllabus. They call it case study, but yes, it is a sim chart. All right, guys. Thank you so much. We didn't have a break, so you get out early. Have a good evening.
Thank you, you too.
You're very welcome, guys.
All right, bye.